and hepatitis E. And later, we will study enteroviruses, but they are a lot. We don't have time to study all of them, and we will focus only in one, polioviruses. So the class today is very long, the same as always. All the classes are very long. So we are here. So we are studying RNA viruses, and today we continue with the study of viruses that cause hepatitis. Hepatitis C belongs to the family Flaviviridae. Hepatitis A belongs to the family Picornaviridae. Hepatitis E belongs to the family Hepaviridae. Enteroviruses belong to the family Picornaviridae. So this is where we are. So we start with hepatitis C. Hepatitis C belongs to the family Flaviviridae. The family Flaviviridae contains many different viruses that infect humans, a lot. In this course of microbiology, we are going to study 4 of them. One is hepatitis C, but not the only one. By the way, flavi in Latin language, flavus, means yellow color. One of the viruses is the yellow fever, hence the name Flaviviridae, flavi, yellow. Flaviviridae contain a positive single-stranded RNA nucleic acid. Remember the meaning of positive sense. The nucleotide sequence of the nucleic acid is the same as the messenger RNA. So this nucleic acid can be translated directly in a protein. This positive sense RNA can work as a messenger RNA. It is translated directly. This is the structure. Positive single-stranded RNA, icosahedral capsid made of proteins, an envelope outside. And the envelope contains glycoproteins. One of these glycoproteins, the protein E, is used by the virus to bind host cell receptors. This is the structure of all Flaviviridae, okay? All of them. Dengue virus, yellow fever, hepatitis C, Japanese encephalitis, all. This structure is common for all flaviviruses. And now we focus in the first one, hepatitis C virus. Hepatitis C virus was discovered 30 years ago. Hepatitis C virus is the cause of hepatitis C, a very important cause in the world of chronic hepatitis, because most patients with hepatitis C virus become chronically infected. After many years of infection, they can develop severe complications, cirrhosis or liver cancer. Important problem in the world. Around 3% of the population in the world are infected. What about in Vietnam? In Vietnam, I am not very sure. I was looking for information about this, and I found this paper, and it seems that the prevalence in Vietnam is very similar to the prevalence in the rest of the world, around 3%. So around 3% of people in Vietnam are chronically infected with hepatitis C virus, much less than hepatitis B virus. So look, what happens when we are infected by hepatitis C virus? We suffer acute hepatitis, and this acute hepatitis is most often asymptomatic. Most people with acute infection do not suffer any symptom. However, unfortunately, patients infected with hepatitis C virus, most of them will become chronically infected. Most of them. This is the problem. We don't know exactly how many, but most of them. Between 50 to 85% of people infected will become chronically infected. Between 5 to 30% of them will develop cirrhosis. And some of them, 25% of them, will develop the most severe complications: end-stage liver disease or hepatocellular carcinoma, liver cancer. Hepatitis C virus is oncogenic, as you already know. The virus is transmitted by the same mechanisms as hepatitis B virus. The most efficient way of transmission is parenteral transmission, so through the blood. Sexual transmission is also possible, but the efficiency of this route is low, but possible. Mostly in men who have sex with men. Mother-to-child transmission is also possible, but not common. So the most efficient is through the blood. So look, patients infected with hepatitis C virus, about 60% of them have acquired hepatitis C virus by injecting drugs, so parenteral transmission. 15% of them through sexual transmission. Not now, but in the past, about 20, 30 years ago, the transmission through the blood by blood transfusion was also possible, about 10%. But currently that is very rare. However, look, in around 10% of people infected, the route of transmission is not known. We don't know why. In 10% of people, we don't know why they are infected. So look, what about vertical transmission? Mother-to-child transmission. Mother-to-child transmission is possible transplacentally, so during pregnancy, or during delivery, at birth. At both times, transmission is possible, but not common. Vertical transmission appears only around 4 to 8% of births, so not many. However, if the pregnant woman is infected at the same time by both HIV and hepatitis C virus, the likelihood of transmission is much higher, 17 to 25%, and we don't know why. But mothers infected by both viruses have a higher probability of transmission to the newborns. So look, I told you before that around 10% of people are infected and we don't know why. So other risk factors for transmission may be the use of drugs intranasally. For example, the use of cocaine. It may be a risk factor to becoming infected with hepatitis C, because maybe the straw that they use to inhale the drug is contaminated with blood. Or cosmetic procedures, tattooing, or body piercing. Why? Because some people go to places for tattooing and for body piercing, and these places are not very clean. The sterilization procedures are not efficient in some places. So if you want a tattoo or you want a body piercing, you must go to a place where they sterilize the material with the autoclave, okay? Because if not, the transmission of some diseases is possible. Hepatitis C, hepatitis B, HIV. In one paper, I found that people with tattoos have a likelihood of suffering hepatitis C 2 times higher than other people. So take care with this. Sterilization of the material is very important. This is the structure of hepatitis C virus. The same as I told you before. This protein at the envelope, the protein E2, this is the protein that the virus uses for binding host cell receptors. You don't need to remember the name of the protein. And this is something very important that I told you in the last class, but I want to explain you today in more detail. Hepatitis C virus is an RNA virus. And we have a problem with RNA viruses. The enzyme that they use for replication and transcription is a viral enzyme. This viral enzyme is called RNA-dependent RNA polymerase. And this enzyme, this viral enzyme, has a problem. Is that this enzyme is not very good during replication. This enzyme makes many mistakes during replication. This enzyme is not able to correct the mistakes during replication. So there are many mutations after replications, many. 1 every 500 nucleotides. This is a very high likelihood of mutation. The enzyme is not very good, and this is a problem. Well, for the virus, many of these mutations are lethal. That means for many mutated viruses, they can't survive. However, other mutations can persist. That means one individual that is infected by hepatitis C virus may become infected by many different strains at the same time. I mean, when one patient is infected by hepatitis C virus, after several weeks, because of these mutations, after several weeks, different strains of the virus may be living inside this patient because of these mistakes. These different strains are called quasi-species. So what is this? You already know the meaning of a species. In Latin language, quasi means almost. So what is this? So one patient becomes infected by hepatitis C virus, one patient. After a few weeks, because of mutations, many different quasi-species are living inside the host. They are not very different, They are different only in 5% of the nucleotides. So they are similar. Their homology is more than 95%. So they are not so different, okay? But this is a problem for the immune system, as you will see later. This problem is not only found in hepatitis C virus. This problem is also found in yellow fever, in dengue virus, in yellow fever, not so much, but in dengue virus, in HIV, and other RNA viruses, okay? So that is the concept of quasi-species. We can also find different genotypes. We talk about genotypes in other classes, okay? Genotypes are viruses more different than quasi-species, and the homology of genotypes is less than 80%. So one patient is infected by one genotype, but one patient may be infected by many different quasi-species. Do you want to explain the meaning of quasi-species in Vietnamese? Maybe they don't understand.
Cô giải thích cho bạn tí là cái virus HCV nó có cái cấu trúc là RNA, thì khi nó xâm nhập vào bên trong cái tế bào của người thì cái quá trình phiên bản của nó xảy ra có rất là nhiều lỗi, cho nên nó sẽ tạo ra rất là nhiều các cái biến chủng. Đó là lý do vì sao mà cái hệ miễn dịch chúng ta nó đáp ứng không kịp và nó có thể dẫn đến cái tình trạng đó là viêm gan mãn tính nha các bạn.
Okay, so look, the infectious process from exposure to disease. Exposure is through the parental route, sexual route, mother to child transmission. So look, hepatitis C virus can bind the target host cells. The target host cells are hepatocytes, the liver cells. They can bind by two different mechanisms. They can bind directly. So the E2 protein from the envelope binds the host cell receptors specifically, the same as other viruses. However, hepatitis C virus can also bind host cell receptors indirectly. Hepatitis C virus can coat itself with lipoproteins, LDL or VLDL. that you already know from biochemistry. So these lipoproteins can bind to their specific receptors in hepatocytes. So the virus can use the lipoprotein receptor to facilitate, to make easy, the entrance inside hepatocytes. What about the damage? We don't know very much about pathogenesis, but we know that most damage seems to be produced by the immune response, the same as hepatitis B, the same as hepatitis C. In very simple words, very simple, the general rule is that for all hepatitis viruses, A, B, C, D, and E, for all of them, most damage is related with the immune response, for most of them. In the case of hepatitis C virus, antibodies cannot protect. Antibodies appear, but they are not protective. And we have another problem. The problem that I told you in the beginning. Most infections become chronic. And we don't know why. We don't know why. Maybe there are many reasons why these infections become chronic. One of the reasons may be that the immune response is not effective against the virus. And why not? Because of the quasi-species, because of the mutations. If the virus mutates very much, the antigens change, and the immune system cannot recognize the new antigens. So this is the same problem that we have with HIV. We will study next week. This is one of the reasons why most infections become chronic, but this is not the only reason. Another reason may be that some proteins produced by the virus may inhibit, stop some functions of the immune system. And another reasons, depending on the host. Not all the people have the same risk of developing chronic disease. At the end of the class, in Complements for Better Understanding, I show you one slide, and I show you something related with these host factors. So some people have a higher risk of becoming chronically infected, okay? The most severe problem in chronic infected people is the liver cancer. After 20 to 40 years of suffering chronic infection, patients have high risk of developing hepatocellular carcinoma, liver cancer, the same cancer caused by hepatitis B. But the mechanisms are not very clear. The mechanisms that cause the mechanisms that cause liver cancer related to hepatitis B are very clear, but not for hepatitis C. We know that hepatitis C virus is oncogenic, but we don't know exactly why. So this is not microbiology, this is clinical medicine, but I have to tell you. Patients who become infected by hepatitis C virus will suffer acute hepatitis. However, most of them are asymptomatic. Most of them, between 70 to 85% of them will be asymptomatic. Some people will be symptomatic. And the symptoms are the same for all acute hepatitis. Jaundice is the most common symptom. But remember, most of them are asymptomatic. And fulminant hepatitis, you already know the meaning of fulminant. Fulminant hepatitis is very, very rare. How can we make the diagnosis of acute hepatitis at the laboratory? The laboratory findings in patients with acute hepatitis are the same as for other acute hepatitis. So remember, increased level of transaminases, ALT, AST, increased level of bilirubin, and in severe patients, problems with coagulation. So this is the same. This is the same as for all acute hepatitis, the same laboratory finding. Chronic hepatitis C is very similar to chronic hepatitis B. However, for chronic hepatitis C, most patients are asymptomatic. Fatigue is the most common symptom in patients with chronic hepatitis C, the most common. So look, this is not microbiology, okay? This is clinical medicine. But medical students should know clinical medicine when they study microbiology. If not, it's useless. So I want to tell you something about clinical medicine. When I was working as a medical doctor, I remember some patients around 40, 50 years old, they came to the hospital with fatigue. Only fatigue, nothing else. No fever, no jaundice, nothing. Only fatigue. And when I ordered some laboratory tests, I found transaminases increased. So this is a patient that complains about fatigue, 40, 50, 60 years old, and increased level of transaminases, only that. Sometimes bilirubin, but not much. So if you have a patient with fatigue and elevated transaminases, you have to think in chronic hepatitis C, okay? Or chronic hepatitis B sometimes. Don't forget hepatitis, okay? Anyway, this is the course of hepatitis C. This is the course. The most common course on the right side. People become chronically infected. So they suffer acute hepatitis and they cannot recover. On the left side, we have patients with acute hepatitis that completely recover. So two types, okay? Recovery, not common, 20%, 15, 20, 30%. On the right side, chronic disease, most of them, around 80%, 85, okay? So how can we make the diagnosis at the laboratory of microbiology? By using two tests, serology, so the detection of antibodies, or PCR, the detection of the RNA, by quantitative means real time, quantitative reverse transcription PCR, okay? So detection of antibodies and detection of the nucleic acid, the same as hepatitis B. And we can find 4 different profiles that we are going to explain in this table, okay? So antibodies and RNA. We try to find these markers in blood. So the first profile, both markers are negative. So this is the typical profile of a patient that has been never infected, so susceptible. Has never infected. However, this profile may be also found in some patients with a past infection. Past infection, so recover, because in some of these patients, antibodies disappear after years. So no markers are found. Okay? Typical profile of never infected people, susceptible. Another profile, the RNA positive and the antibodies negative. So the virus is replicating, okay? So this patient is infected. However, we don't find the antibodies. Why not? Because it's very early. And antibodies need 6 to 8 weeks, 6 to 8 weeks to appear. So this is a patient infected by the virus. This is a patient with an acute infection. Acute infection very early, so before 6 to 8 weeks, because antibodies appear after this time. This is the profile of an infected patient. Another profile, we find antibodies, but we don't find the RNA. So this virus is not replicating, okay? But we find the antibodies. So this patient is infected or has been infected in the past. This is possibly a past infection. Past infection recovered. Very few patients recover, okay? Very few. However, we will say something later about this, okay? Because this is not always true. I will tell you later. And finally, both markers are positive. So the virus is replicating, and we find the antibodies already. So this patient is infected. Possibly chronic, possibly. But acute disease is also possible. So we cannot differentiate. The virus is replicating, but because chronic diseases, chronic hepatitis is more common than acute hepatitis, this patient is possibly chronic, okay? But acute is also possible. About this patient, because one of the students asked me before, one of the students of the other class asked me, we find the antibodies, but we don't find the RNA, okay? And we say past infection, possibly recover. However, the recovery after hepatitis C is not common, as I told you. So we have to take care with this negative value, okay? Because we need to retest later. So retest, so test again, the PCR after several weeks. And to check that this is truly negative, okay? So if we find that the PCR is negative 2 times, we can say that the patient has been recovered, okay? But sometimes this is a false negative by different reasons that we cannot explain here. So do you have any question about this? Any question? Is the same? Any question about the diagnosis of hepatitis C? No. Or do you want to say something? Well, no, one say no. Other keep silent.
Các bạn có thắc mắc gì ngay chỗ cái chẩn đoán nào không ạ?
Okay, so we continue. In the last 5 years, we found a very good antiviral treatment, very effective, to cure patients with chronic hepatitis C, using the combinations of many different antivirals together. Most of these antiviral drugs appeared 5 years ago, and they are very good. The problem is that they are very expensive and they are available only in some places, but they work very well. The purpose of this class is to explain very basic things about hepatitis C. So we cannot explain this treatment. This treatment is very complex. If you are interested in the antiviral treatment, because maybe you have someone that you know that is infected, trusted information can be found in this link, okay? Here, you can find how to treat all genotypes of hepatitis C with a very deep detail, okay? So I suggest you to go here if you are interested, because this information, the recommendations to treat patients with hepatitis C change very quickly, almost every month, okay? So here you can find trusted information. We don't have any vaccine. To make a vaccine is very difficult, as you can imagine. Why is so difficult? Because the virus changes very much. So we are doing some research to find a vaccine, but still in phase 1, clinical trials. So currently we don't have any vaccine. The only way to avoid the spread is to follow the same recommendations that we follow to avoid the spread of hepatitis B. So safe sexual practices, so using the condom by males, or not sharing personal items like toothbrushes or razors or needles. And for people with chronic disease, alcohol drinking should be stopped because it increases the liver damage. This is also true for patients with chronic hepatitis B or chronic hepatitis D, the same. Do you have any question about hepatitis C in general before we continue? Any question? Silent?
Why is this name C?
Sorry?
Why is it named C?
Can you repeat, please? I cannot hear you clearly. You understand?
Why does it have a name C?
Ah, the name C. Yes, yes, I understand. Okay, yes. Yes, the name C. That's a very interesting question. The name C was applied 30 years ago. I show you here. The first viral hepatitis that was recognized was hepatitis A, obviously. The second one was hepatitis B. And later, 30 years ago, when I was a child, we had many patients that had hepatitis, but we didn't know why, because this virus was not discovered until 1989. So these patients with hepatitis, chronic hepatitis, that were not infected with B and not infected with A, but we didn't know why, we call them no A, no B, because we didn't know why. And in the year 1989, one biologist discovered that these patients with this disease were infected with a new virus. So this new virus was called C. Okay, that is the reason. You understand? So we had patients with hepatitis, but we couldn't identify any virus because the virus was unknown. So we call them no A, no B. Even now, when I meet some patients, very old, and I ask them, do you have any disease? And they say, yes, I have hepatitis no A, no B. And we are very confused. And we say, no, 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 you have hepatitis C, okay? Because now we know the virus. That is the reason why the name is C.
Okay, thanks.
And later we discover D and E, okay? And even F and G. But later we know that these viruses do not cause hepatitis. But that is another story. More questions?
No.
Okay, so we continue. I think I explained you that here in the class, but I'm not sure. Anyway, hepatitis. We can divide all hepatitis into two big groups. Two big groups, okay? All viral hepatitis. The chronic hepatitis and the acute hepatitis, okay? Well, chronic, no, I'm going to change this, not chronic. We are going to say the parenteral hepatitis. Parenteral transmitted hepatitis. Parenteral transmitted hepatitis are hepatitis B virus, hepatitis D virus, and hepatitis C virus, okay? Remember that these are also transmitted by sexual contact, okay? And the other group, and these hepatitis, these B, D, and C, they can become chronic sometimes, or many times. Hepatitis C, many times. Hepatitis D, many times. Hepatitis B, not many. And the other group are acute hepatitis. These acute hepatitis are hepatitis A virus and hepatitis E virus. And we study them separately because they do not become chronic. Okay, we study them separately. That's why we study hepatitis E and E together here. So they cause acute hepatitis, but not chronic hepatitis, with one exception that I will tell you later. So hepatitis A and E share common features. They cause symptomatic disease. This is not so common for hepatitis B or C. Symptomatic disease, usually mild. They do not become chronic. However, in the last few years, we know that some patients immunocompromised with hepatitis E may become chronic. But this is very rare, but it may happen, okay? In general, the general rule is hepatitis A and E do not become chronic. they are transmitted by the fecal-oral route, and this is new. Hepatitis B, C, and D cannot. And hepatitis A and E usually infect young people. Acute hepatitis in young people. Hepatitis A virus belongs to the family Picornaviridae. Hepatitis E virus belongs to the family Hepaviridae. If you read old textbooks of microbiology, they say that hepatitis E belongs to the family Caliciviridae. Currently, the family of hepatitis E virus is Hepaviridae, has been changed, okay? But you can still find Caliciviridae in many textbooks. So we are going to start with hepatitis A virus. Hepatitis A virus belongs to the family Picornaviridae. The Picornaviridae family contains a lot of viruses, a lot, that we are not going to study, okay? Picornaviridae contains hepatitis A virus that we are going to study now, and also enteroviruses that we will study later, okay? So all of these viruses belong to the family Picornaviridae. So we are going to study now hepatitis A virus. By the way, the name Picornaviridae, Viridae, family of viruses, RNA, Pico, Greek language, it means very small. So very small RNA viruses, okay? That's the meaning of Picornaviridae. I promise that because I know that the language of microbiology is very difficult. I promise that I always try to explain you the meaning of the words, okay? Not always, because sometimes I don't know. But if I know how to explain, I will explain. So the words in microbiology have a meaning. I always try to explain, like hepatitis C, for example. Anyway, we are going to study hepatitis A viruses now, and later enteroviruses. That are so many. So look, the family Picornaviridae is very similar to the family Flaviviridae that we studied before. They are very similar. It seems that the only difference is that Flaviviridae have envelope and Picornaviridae do not have envelope, but they are very similar. The nucleic acid is also positive single-stranded RNA. So it can be translated directly into a protein. They are translated directly. They don't need transcription because they are already messenger. They are translated directly in a polyprotein, the same as Flaviviridae. Polyprotein means, well, poly means a lot, protein. So polyprotein is a long protein made of many different proteins. They will be cut later. And look, we are going to start with hepatitis A virus, okay? It's a problem found all over the world. However, in the last years, the incidence has decreased very much. Why? Because it's transmitted by the fecal-oral route. All microorganisms transmitted by the fecal-oral route have decreased in the last years because sanitation and hygiene have improved. And also because we have a vaccine. Both reasons. Antibodies are protective. So when we are vaccinated, we are protected, okay? The transmission is through the fecal-oral route, from stool of an infected patient to the mouth of a healthy patient. Fecal-oral route from person to person is possible, but also through the food or through the water. This is also common. For example, it's very common with contaminated vegetables or shellfish. This is very common, shellfish. Because something that I can explain you later if you want. You can find in the compliance further understanding. Anyway, from person to person, through the food or through the water. Hepatitis A virus is very resistant. It can survive a long time in the environment. Why? Because it doesn't have envelope. I told you in the first class that viruses without envelope are very resistant in the environment. This is the problem of hepatitis A in the world. Most cases appear in places with a poor sanitation. Sub-Saharan Africa, India, and surrounding countries. Pakistan, Bangladesh, Afghanistan. This is what happens when we are infected. Exposure through the mouth, oral ingestion. From the mouth, the virus goes to the intestine. And look, this is very interesting. Because hepatitis A virus can replicate in the intestine, in the intestinal mucosa. So look, hepatitis A virus replicates in two places, in the liver, of course, hepatitis, but also in the intestinal mucosa. This is the only hepatitis virus that can do this. So the hepatitis A virus can infect some cells in the intestine and replicate in the intestine. Not very much, but enough to increase the number of virions. These virions cross the intestinal wall, cross the intestinal mucosa, and they go to the blood. That's viremia. And from the blood, they can go to infect the target host cell, the hepatocyte in the liver, and they cause hepatitis, lytic infection. When they are in the liver, they replicate a lot in the liver, and they are released, shed in the bile, from the bile to the stool. So they are excreted, released in stool. This is the reason why these viruses are transmitted through the fecal-oral route. What about the damage? The damage mostly depends on the immune system, the T-cell response. So a strong immune response is related with severe disease, the same as for other hepatitis viruses. This is the reason why children are usually asymptomatic, because the T-cell response in children is not so strong. So adults infected may become very symptomatic. Children infected, asymptomatic or very mild, okay? And this is very interesting. This is very interesting because, look, when I was a child, 30 years ago, 30, 40 years ago, hygienic sanitation was very poor. So most children were infected by hepatitis A virus. We were infected in school. And we didn't notice anything because the infection in children is asymptomatic, okay? We developed antibodies and we were protected forever against hepatitis A. However, currently, sanitation has improved a lot. So children are not infected in school. So they are susceptible when they become adults. So some adults may become infected now and they will suffer a symptomatic disease. This is very interesting. Do you understand the problem? So sanitation improves, yes. But if we suffer the disease, as an adult, we will suffer a more symptomatic, more severe disease. This is the same problem as Epstein-Barr virus. A long time ago, when sanitation was very poor, children infected very easily with Epstein-Barr virus, and they suffer an asymptomatic disease. But now sanitation is better, okay? Anyway, acute hepatitis completely recovers. Very few patients die. Only 0.1% of the patients will die. Acute hepatitis A will never become chronic. All people recover. Patients with acute hepatitis have the same findings independently if they are infected with virus A, B, C, or E. The findings are the same. And the laboratory findings are the same as for other acute hepatitis. Increased transaminases, increased bilirubin, or sometimes increased impairment of the coagulation. But that is only found in patients with severe disease. So the findings are the same for all patients. Hepatitis A cannot be differentiated from other forms of acute hepatitis. It's the same. The outcome is very good. Most patients recover in very few months. So look, the diagnosis of hepatitis A virus is made at the laboratory of microbiology by serology, detecting antibodies, IgM or IgG. Remember, as always, from the second class, IgM is the first antibody that appears. So the finding of IgM is related with acute disease. However, IgG appears later. So the diagnosis of acute hepatitis A is made at the laboratory of microbiology when we detect a specific IgM. A patient with IgM positive is a patient with acute infection. However, take care, because if we test the patients very early in the disease, 10% of them may have the test negative, because IgM requires a time to develop, okay? So if the patient is suffering acute hepatitis and the IgM test is negative, you have to test again after 2 weeks. After that, IgG appears, and IgG persists for many years, and IgG will protect you forever. So you suffer hepatitis A only once in your life, because IgG protects you. So look, this is not microbiology, this is clinical medicine again. Acute hepatitis is a common disease. It may be produced by viruses, but also by toxins like alcohol or other toxins, okay? So when you have a patient with acute hepatitis and you don't know why, the tests that you have to order to the laboratory of microbiology are these: the surface antigen of hepatitis B, the anticore, antibodies against the capsid of hepatitis B, antibodies against hepatitis C, and the IgM against hepatitis A. So with these markers, you can have an idea. These markers can help you in the diagnosis of acute hepatitis. But acute hepatitis is also possible by toxins or by other viruses. For example, cytomegalovirus, Epstein-Barr virus, many other viruses may cause acute hepatitis, okay? So these are the markers that you have to order in the beginning to help you in the diagnosis of acute hepatitis. This is not microbiology. This is clinical medicine. We don't have any antiviral treatment against hepatitis A. So the treatment is only symptomatic, supportive. Sometimes patients require to be hospitalized, mostly patients with failure in the coagulation, but this is very uncommon. We have a vaccine. Pre-exposure prophylaxis is made with a vaccine. The vaccine is given intramuscularly, 2 doses. The vaccine is indicated for people older than 1 year, because in babies younger than 1 year, the vaccine doesn't work. So we can perform the pre-exposure prophylaxis with the vaccine, the best, or with immunoglobulins, with antibodies. This is recommended for children that need it before 1 year, if they need it for any reason that we don't know, okay? Or for people that need to become protected, but they cannot receive the vaccine for another reason that we don't know, okay? So the best way to perform pre-exposure prophylaxis is the vaccine. Any question about hepatitis A before we continue?
Please continue.
Do you want to say something? Questions?
Please continue.
The other students keep silence. So we continue. Okay, so we continue. Hepatitis E virus, the last one. Why hepatitis E? Because it was the last discovered. Not the last, but almost the last. Family Hepaviridae. What's the meaning? Very easy. Viridae means family of viruses. Hepatitis E virus, Hepaviridae, okay? That is the meaning. Very easy to remember. Hepatitis E virus was discovered a long time ago. Well, not the virus, but the disease, okay? The disease was discovered a long time ago, and in the beginning, the virus was classified inside the family Calliciviridae. And later, the virus was classified inside the family Hepaviridae. So look, hepatitis E virus is the cause of acute hepatitis. This acute hepatitis is very similar to acute hepatitis A. Very, very similar. They don't cause chronic disease, except, as I told you before, except in immunocompromised people. Some immunocompromised people may develop chronic hepatitis E, but this is not common. This is very rare. Hepatitis E virus is transmitted also by the fecal-oral route, but from person to person is not common. Hepatitis E virus is mostly transmitted through contaminated water in endemic areas. However, hepatitis E is also zoonotic. It can be transmitted by some animals, the pigs. Some serotypes of hepatitis E can infect the pigs, and they can transmit the disease to humans. So look, you already know many diseases that have been transmitted from pigs to humans, like Streptococcus suis and many that I don't remember now, okay? So hepatitis E is zoonotic. This is the only hepatitis virus that is zoonotic. And look, in Vietnam, we have a very high incidence of hepatitis E, but I don't know how much. I was trying to find the data, but I didn't find. But this is also a problem in Vietnam, hepatitis E. Hepaviridae family, the nucleic acid is also positive single-stranded RNA, okay, without envelope. So they are very resistant. What about the damage? The pathogenesis, we don't know very well, but it seems that most damage is related with immune response. What's the difference with hepatitis A? Hepatitis E virus cannot replicate in the intestine. This is one difference with hepatitis E. To my knowledge, hepatitis E replication is only possible in the liver, to my knowledge. Antibodies are also protective, the same as hepatitis E. However, we don't have a vaccine against hepatitis E. When we suffer hepatitis E, we produce antibodies, and these antibodies are protective, but we don't know for how long. We don't know, because we know that the IgG slowly disappears, okay? So we don't know how long we are protected. Patients who become infected by hepatitis E develop acute hepatitis, very similar to hepatitis A. However, one difference with hepatitis A. Fulminant hepatitis is more common in patients with hepatitis E, between 0.5 to 3% in the general population. However, pregnant women may suffer fulminant hepatitis. We don't know why. but pregnant women have a higher risk of developing a fulminant hepatitis. The mortality is very high in pregnant women. We don't know why. This is a difference with hepatitis A, fulminant hepatitis in pregnant women. We don't know why. Maybe because in pregnant women, the virus is replicating more, but we don't know why. Remember, the general rule is that chronic hepatitis E does not exist. For many years, we thought that chronic hepatitis E didn't appear. Currently, we know that some patients immunocompromised may develop hepatitis E. But this is very rare. This is not common. And these patients are usually solid transplant recipients or HIV-infected patients. When immunosuppression disappears, these patients recover. So this is not very common. This is the profile of a patient infected with hepatitis E virus. The same as hepatitis A. In the beginning, IgM appears. This is the first antibody that appears, and later IgG appears, and decreasing later. So the diagnosis of acute hepatitis E is made by the detection of IgM against hepatitis E. So the same as for hepatitis A. The diagnosis of hepatitis E is made by IgM detection. The treatment of hepatitis E is also symptomatic, supportive. We don't have specific antivirals. However, this is not important, but I have to tell you. For patients with chronic infection, so immunocompromised patients, some people are using ribavirin to treat them. Ribavirin is an antiviral that we explained in the self-learning topic 5, and this may be useful for patients with solid transplants that are chronically infected with hepatitis E. Okay? But the general rule is to treat only symptomatically. We don't have any vaccine, but vaccines are on development. Do you have any question about hepatitis A or hepatitis E? Any question? Questions? Hoy, do you want to ask something or to answer something? Hoy.
I'm here already. Tụi em có câu hỏi gì không?
Questions?
Không.
Okay, so we stop 5 minutes, okay? And we continue later. 5 minutes. And we are here 5 minutes, and later we continue with enteroviruses. Okay, so we continue with the class. Are you there?
Yes, I'm here.
Yes.
Okay. Did you go to the toilet? Silence?
Yes.
Good. So now we can continue much better. Okay, so we are going to continue with the family Picornaviridae. And we are going to study enteroviruses. They are a lot. We are going to focus in only one. Polioviruses. These are enteroviruses, okay? We can make two groups of enteroviruses, rhinoviruses and enteroviruses. Rhinoviruses are respiratory pathogens. They cause upper respiratory infections, very mild, the common cold. Rhinoviruses are the most common cause of the common cold. The second one, coronaviruses. And enteroviruses are very different. We have a lot. They cause many different diseases in many different places. We are going to focus only in one, enterovirus C, polioviruses, this one. But that is for later. So before that, we are going to say some things common for all enteroviruses, all of them. Enteroviruses are found everywhere. Take care. Entero means intestine, okay? However, enteroviruses do not cause intestinal disease. So why do we call them enteroviruses? Because they replicate in the intestine. And they are usually spread by the fecal, they are transmitted by the fecal oral route, but they don't cause disease in the intestine, as a general rule. So look, transmitted by the fecal oral route from person to person, usually. And they also contaminate the environment, for example, the water, so the transmission of the viruses is easier. Like all microorganisms that are transmitted by the fecal oral route, poor sanitation, poor hygiene, and crowded living conditions increase the spread. So what about the viral cycle? We are going to put this information in the whiteboard more clear. What happens when we are infected? I'm going to do it here. So from exposure to disease, as always. So exposure, fecal oral route. So exposure is through the oral route, oral ingestion. After that, the virus starts replicating in the pharynx or in the tonsils, in some cells of the pharynx or the tonsils. So look, this is the first replication of the virus. So we can say that this is the replication number 1. So enteroviruses at first replicate in the pharynx or in the tonsils. After that, viruses go to the intestine. In the intestine, they infect different cells. For example, the M cells that you will study in immunology next year, or lymphocytes, or enterocytes, many different cells, okay? And they replicate here again. So this is the second replication. We can say that this is the replication number 2. And they replicate a lot in the intestine. This is the reason why these viruses are spread in stool and transmitted through the fecal oral route. From the intestine, they cross to the blood. So they cross the intestinal wall and they enter in the blood. This is called viremia. And from the blood, they can find their final target. So they are spread, looking for the final target host cells. And these final target host cells are so many. Some viruses infect the skin. Some enteroviruses infect the heart. Some enteroviruses, the brain, or the pleura, or the motor neurons. or meninges, some of them cause meningitis, or many other sites. We have many different enteroviruses that can infect many different sites of the body. In these final target host cells, they also replicate. So this is the third replication. So we can say in very simple words that enteroviruses can replicate until 3 times in 3 different places. The final target host cell may be very different tissues, okay? This is common for all enteroviruses. In this class, we are going to focus in enterovirus group C. These are the so-called polioviruses. The final target host cell for polioviruses are motor neurons. So polioviruses infect motor neurons, infect and destroy motor neurons in the spinal cord or the brainstem. Okay, this is the purpose of this class. Most infections caused by enteroviruses are subclinical or asymptomatic. More than 90% of poliovirus infections are asymptomatic or subclinical. So look, so we are going to focus in polioviruses. Every year, when I teach this class, I always show this picture to the students and I ask them if they find something strange in this picture. And all the students say, yes, the leg. The leg is very thin. This picture was found in a stone in Egypt, and it's from 3 years ago. So this is the oldest record that we have of poliomyelitis. Poliomyelitis was a terrible disease that caused flaccid paralysis. Look the leg. So we are here. Polioviruses are the cause of poliomyelitis. The most important enteroviruses in the world are polioviruses. And we can find 3 wild serotypes, but I want to explain this in the whiteboard. So currently, sorry, where we are here. I'm going to write here. So currently, polioviruses that cause disease may be grouped into 2 types. The wild type, wild viruses. Wild means natural. And we have 3 types. We have serotype 1, serotype 2, and serotype 3. So these are serotypes of polioviruses. Type 1, type 2, and type 3. And we have another group that I will tell you later. Serotype 2 has disappeared from the world. It has been eradicated. This serotype was eradicated in 2015, so very few years ago, disappeared forever. And one difference with the class that I was teaching last year, serotype 3 was eradicated very successfully in October. I mean, in October of last year, so 6 months ago. And this was a great medical achievement. Serotype 3 has been eradicated. So currently, the only wild natural poliovirus that we have in the world is the serotype 1. 6 months ago, the World Health Organization announced very proudly that we could eliminate forever the serotype 3. How? Because of vaccination. In the last 40 years, there have been very strong efforts to vaccinate all children in the world. 6 months ago, serotype 3 disappeared. So currently, the only wild serotype that we find in the world is the serotype 1. However, polioviruses, serotypes, I told you that we have 2 types. So we have another type, another group of serotypes that are also found in the world. These are called, I write the word and I explain you later. These are called circulating vaccine-derived polioviruses. So circulating vaccine-derived polioviruses. We have also 3 serotypes, serotype 1, serotype 2, and serotype 3. And what are these viruses? These are viruses that appear because of mutations of one of the vaccines. So at first, these serotypes were serotype 1, serotype 2, and serotype 3, and they were used for vaccination. Sometimes the viruses in the vaccine mutate, and they become mutated viruses. So they are not natural. They are non-natural viruses. They appear because of mutations. After mutations of the viruses in the vaccine. So currently in the world, poliomyelitis may be caused by 4 different viruses. Wild serotype 1, vaccine-derived 1, vaccine-derived 2, and vaccine-derived 3. 4 viruses. Oi, do you want to explain what is this? The circulating vaccine-derived polioviruses? I'm not very sure if it's clear.
Trong các cái phần tự đọc đấy bạn biết là cái vaccine nó được tạo ra từ rất là nhiều các cái cách khác nhau, thì trong đó có cái vaccine đó là sống giảm độc lực các bạn. Thì các cái chủng virus mà hiện nay người ta sử dụng trong cái bài liệt thì người ta có thể sử dụng các cái chủng virus có biến đổi để làm mất đi cái hiệu lực gây bệnh của nó, nhưng mà vẫn giữ được cái cấu trúc kháng nguyên để mà kích thích cơ thể đáp ứng miễn dịch.
So we are here. Humans are the only host for polioviruses, not animals. They are never found in animals, and this is very good, because that means that if we eradicate, if we eliminate the disease, the virus in humans, the disease will disappear forever. Polioviruses infect the motor neurons and destroy the motor neurons, as I told you before, in the anterior horn cells of the spinal cord or in the brainstem. So when these motor neurons are destroyed, the outcome is paralysis. That's poliomyelitis. Poliomyelitis is flaccid paralysis of the limbs, usually of the limbs. So look, I'm not sure if you know anatomy. I don't know. So motor neurons are found here in the anterior horns of the spinal cord. This is the spinal cord, and this is the anterior horns. This is the place here, here, and here, where we find motor neurons, okay? Bigger, here, here, and here. Polioviruses infect and destroy these motor neurons that we find here. So the outcome is paralysis. You don't know because you are very young, but I have to tell you, because this is very important. When I was a child 40 years ago, poliomyelitis, polio, was one of the most feared diseases in the world. Most children became infected. Poliomyelitis was the cause of hundreds of thousands of paralysis in children every year in the world. I repeat, hundreds of thousands of children suffer paralysis every year, 40 years ago. And that was terrible. However, young people don't know about that. We know that poliomyelitis is a terrible disease that must disappear. The only way to fight poliomyelitis is vaccination, the only way. In the last 40 years, the world have made strong efforts, and the governments of many countries, also the Vietnamese government, to eradicate, eliminate poliomyelitis. So every year when I teach this class, I show this slide with very big letters, because I want that you, young people, understand how important vaccination is. Vaccination against poliomyelitis is one of the world's greatest medical achievements, because poliomyelitis is a terrible disease that makes children paralyzed forever. And the vaccine is extremely cheap, as I will tell you later. This is very, very important. Until now, only one infectious disease has disappeared from the earth: smallpox, variola major. Variola major, smallpox, disappeared from the earth 40 years ago. Why? Because of successful vaccination. If we are lucky, poliomyelitis will disappear in very few years. If we are lucky, and if we are not stupid. If we are not stupid, poliomyelitis will disappear. You will understand later why I say that. Anyway, when we explain here infectious diseases, we always explain the vaccines at the end. However, today we are going to explain the vaccines in the beginning, because this is the most important part of the class, the vaccine. Vaccines against poliomyelitis, very effective, very safe, and very cheap. We have vaccines, very good vaccines against poliomyelitis. We have two vaccines, and this is important, and you must remember the name of these vaccines. The first vaccine that appeared is the Salk vaccine. The Salk vaccine is inactivated. This appeared in the year 1952. The second vaccine that appeared in the year 1960 is the Sabin vaccine. This is a live vaccine. Both have advantages and disadvantages, both. And we are going to write them in the table. Advantages of the Salk vaccine. This vaccine is very safe. It's the safest. Another advantage, this vaccine is very effective. It works very well. Currently, the Salk vaccine is the most commonly recommended vaccine in the world, the Salk vaccine. Disadvantages, it's more expensive, but not very much. It's more expensive than the other one, but it's also cheap, so not so expensive. Another disadvantage, the vaccine is given intramuscularly, so injection. Intramuscular injection, so we need special equipment. So the price is more expensive because we need the needle and the syringe. Intramuscular injection. And because it's given intramuscularly, the vaccine does not provide enough antibodies in the intestine. So no antibodies are produced in the intestine. Remember, enteroviruses mostly replicate in the intestine. So with this vaccine, we cannot stop the disease in the intestine. We can stop the disease in the blood, but not in the intestine. From immunology, for the next year, the antibodies that are released in the intestine are IgA. But this is for next year. So no antibodies in the intestine. So the disease is stopped in a later stage. We stop the disease, I deleted it. Anyway, we stop the disease in the blood, not in the intestine. What about the other vaccine, the Sabin vaccine? Advantages of the Sabin vaccine. Very important, it's given orally. Drops, very few drops in the mouth. So we don't need a special equipment. This is the reason why this vaccine is extremely cheap. Very cheap. One dose of this vaccine costs 3,000 dongs. 3,000 dongs, okay? So cheaper than the bus ticket in the night. Very cheap. And a very important advantage, because this vaccine is given orally, the vaccine is a virus, and this virus is alive. Because the vaccine is given orally, the vaccine replicates in the intestine. So the vaccine is released in stool. So if sanitation, hygiene is not good, the vaccine also goes to other people. So other people also become vaccinated. Do you understand this? The vaccine is released in stool. The vaccine is a virus and the virus is alive. If hygiene is very poor, other people may become contaminated with the vaccine. So they will become vaccinated. So when we use this vaccine in one child, we are vaccinating many children at the same time. Do you understand?
Yes.
Yes, the same mechanism as the.
Is it clear? This is very
Yes.
important. We vaccinate one child, but in these places, hygiene is very poor. So many people around the child will also become vaccinated because the vaccine is spread in stool. This advantage has been very, very important, decreasing the incidence of poliomyelitis in the world. So this vaccine has been very successful, the Sabin vaccine. However, currently, we only use this vaccine in some places, not many. Why? Because the Sabin vaccine has a disadvantage. The Sabin vaccine is alive, so it's less safe. Why? Because the virus in the vaccine, the viruses in the vaccine can mutate. And sometimes if they mutate, they can cause disease. They can cause paralysis. So the virus of the vaccine can cause paralysis if the virus mutates. So this vaccine is less safe. However, how often does this happen? How often? One case every 2.7 million cases. So this is ridiculous. How much is this? 0.00004%. So nothing. So very few people will suffer this complication. This is ridiculous. So this risk is accepted because the risk of this is very low. However, because the risk of paralysis exists, most countries where poliomyelitis has disappeared are using the Salk vaccine, not the Sabin vaccine. When I was a child, I was vaccinated with the Sabin vaccine. You have been vaccinated with the Sabin vaccine, okay? However, now in most countries, in my country, for example, people are vaccinated with the Salk vaccine. When I was a child, the Sabin. Now, the Salk. What about Vietnam? I am not very sure. Until now, children in Vietnam have been vaccinated with the Sabin vaccine. Even now, even this year, children are vaccinated with the Sabin vaccine. However, to my knowledge, but I am not very sure, to my knowledge, this year in Vietnam, at least one of the doses of the vaccine is the Salk already. But I am not very sure, okay? So you have to ask this information to your teacher of public health because this information is important, okay? So I think this year, the Vietnamese government is changing from the Sabin to the Salk, maybe, okay? But I am not very sure. We have to check that information. So this is very important for you and you must remember, okay? So we are here. We are here. This is the way how we vaccinate children with the Sabin vaccine. Few drops in the mouth. So we don't need medical doctors for this. We don't need nurses for this. Anyone All the people can do this because the vaccine is very easy to give. Very few drops in the mouth. This is the reason why this vaccine is excellent, because it's very cheap and very easy to give. When we do this, we can protect the child forever. This is very important. With 3,000 dongs, we avoid that the child suffer paralysis forever. The vaccination of children against poliomyelitis is a great medical achievement and very cheap. We have to do it. I want to repeat it many times because you are very young and you don't know the problem of poliomyelitis in the past. I will show you some pictures later. So, currently, poliomyelitis is caused in the world by 4 viruses, as I told you. The wild serotype 1 and by 3 serotypes that come from the vaccine mutated, from the Sabin vaccine that mutated. So this infection, poliomyelitis, was very common in infants, so small children, younger than 1 year, and young children. However, currently, this disease only appears in countries where vaccination is very poor. I will tell you later. Paralysis appear in very few people. Paralysis appear in 0.1 to 2% of children. So you can say, okay, this is not much. Yes, this is not much. The problem is that when I was a child, most children became infected. So when many children become infected, 0.1% is a lot. That was the problem, okay? Paralysis appear in many children, even when this outcome is not common, because most infections are asymptomatic. Paralysis were spinal paralysis. So this is flaccid paralysis of the limbs, usually the legs, or bulbar cranial paralysis. This is paralysis of the muscles of the head. So this happened when the motor neurons of the brainstem were destroyed. So paralysis of muscles of the pharynx, of the vocal cords, or paralysis of respiration. This was the most important complication, okay? So look, this is not Vietnam. This is, I think this is India. Look, this is the appearance of children affected of poliomyelitis. Look the legs. If you remember the picture in the beginning that I showed you from Egypt, this is flaccid paralysis of the leg. In Vietnam, you are not going to see children in Vietnam like this. No, this is not. This is not found in Vietnam. However, in Vietnam, you are going to meet people around 30 years old, 40 years old, 50 years old with the leg like this. Maybe you haven't noticed before, but now that you already know poliomyelitis, when you walk on the street in Vietnam, you are going to meet many people every day, 30 years old, 40 years old, with the legs like this. A lot. Please check it, because you are going to meet a lot. Because poliomyelitis was a very serious problem in Vietnam 30, 40 years ago. Every year I show this picture. This is a Vietnamese child in time for Ho Chi Minh 30 years ago who suffered poliomyelitis. So look the legs. And this paralysis is forever. I met many people, when I was living in Tan Ho Chi Minh, I met many people around 34 years old, like me, that couldn't move at all because they suffered paralysis because of poliomyelitis. This will not happen anymore in Vietnam because poliomyelitis has disappeared in Vietnam in the last 20 years. This was a problem 30 years ago. This is the problem in Vietnam. People around 30 years old, 40 years old, this is a picture from Tan Ho Chi Minh 5 years ago, and all of them suffered paralysis in the limbs because of poliomyelitis, okay? I show you the picture because I want that you understand how important vaccination is, okay? And this will not happen anymore. here. In the past, poliomyelitis was very important and many people died because of respiratory failure. So respiratory failure was the most severe complication. Some people had to live inside these lungs. This is an iron lung. Look, this is a hospital in the US 50 years ago, 60 years ago. There were many epidemics of poliomyelitis, and children and adults had to live inside this iron lung because they couldn't breathe. This patient is very old, well, very old. It's not a child, I mean, and she was living in the iron lung forever because of paralysis of the respiratory muscles. In the last, this is not microbiology. This is public health, but this is very important and I want to tell you, okay? So in the last 40 years, there has been a very strong effort of the World Health Organization and UNICEF and the governments of many countries, including the Vietnamese government, to eradicate poliomyelitis in the world. So the program started 30 years ago when I was 12. And in this time, more than 2,000 million children have been vaccinated against poliomyelitis. We have eradicated, we have eliminated poliomyelitis from most countries in the world, but not from everywhere. Unfortunately, we still suffer poliomyelitis in some countries in the world. Why is this possible? I don't know why it is possible, because the vaccine is very cheap and the vaccine is very easy to give. As I always say to all my students, I repeat the same many times, this is possible because humans are very stupid. And because humans are very stupid, we suffer wars. We suffer strange religious beliefs. So because of that, vaccination in some places is very difficult, even when the vaccine is extremely cheap. So this is related with the stupidity of humans, unfortunately. What about Vietnam? This problem will never appear in Vietnam anymore because Vietnam is free of polio since the year 1996. The last case of paralysis because of polio appeared in 1996. However, Afghanistan, Nigeria, Pakistan, you know, Afghanistan, there is a terrible war with the US. Nigeria, very poor country with many people. Pakistan, war again, and very poor. They suffer poliomyelitis in children. It has not disappeared by the wild type serotype 1. And currently in Africa, we are suffering outbreaks of poliomyelitis related with mutations of the virus. These are the cases of poliomyelitis last year. So as you can see, there are not many cases. This is 1 year. In 1 year, we have 400 cases. In 1 year, this is nothing, okay? So we are going to eliminate poliomyelitis in the next few years, but not yet, okay? They have increased. This is the year 2018. In 1 year, the cases have increased a little bit. Why? Because of the war, okay? Because of the wars here and because of the wars here. That is the problem of poliomyelitis, the war, not the virus, okay? So the problem is humans, not the virus. So in the year 2019, we had cases by wild serotype 1 in Pakistan, Afghanistan, and we had many cases in Africa related with the vaccine. And the cases the last year increased respect the year 2018 because of the war and because of poverty. Any question about poliomyelitis? Any question? Oi, do you want to say something? Oi, do you want to say something? The vaccination, the difference between the vaccines and understanding the problems of the vaccine is the most important part of the class. Do you want to say something? Silence. Nobody says anything.
Question.
Yes, question.
Why is the Salk vaccine is safer?
The Salk vaccine is safer because the virus is killed. The virus is not alive. The virus is inactivated.
Oh, okay. Yeah, thank you.
And the Sabin vaccine is alive.
Yeah. Thank you.
Questions? Questions? So one dose. Yeah, it's only one dose. The last dose is that one. Any more question? More question? No? Okay, so we have to talk about the exam, okay? So don't go, because we have to talk about the exam. So, the exam. The midterm exam for you, according to the university rules, so this is the university rule, not my rule. The university says that your midterm exam will be next Monday at 9. So, wait, sorry. Your midterm exam will be next Monday at 9. So, during the class, okay? During the class, you will have the midterm exam online. So, how is the exam? 10 points for the exam. The exam has 3 parts. The first part, multiple choice questions, test. 20 to 30 questions, I don't know. Around 20 to 30, maybe 25, okay? So these questions, the multiple choice questions, will be 3 points, so 30%. Second part of the exam, fill in the blanks. We will give you a table with infectious diseases, with blanks, and you have to fill the blanks, okay? I will show you an example later. Between 10 to 12 questions, I don't know yet. And these are also 3 points. And the last part are short questions to write in English language. 2 questions, 4 points. So 2 points per question. The short questions will be clinical cases. For example, like this is a 20-year-old woman that goes to the hospital with sore throat and blah, 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 whatever. And I will ask you some questions, okay? About the diagnosis, about the treatment, about the microorganism, I don't know yet, okay? Something like that will be a clinical case. In the class, we have discussed many clinical cases, a lot, okay? So they will be related with that, with clinical cases. So what about fill in the blanks? What is this? This is an example, okay? This is an example. So this is an example with viruses. The exam is for bacteriology, not for biology. So this is an example. So we will give you a table like this one, with information like this: transmission, disease, clinical findings, laboratory findings, and other information, okay? So this is an example. Transmission, contact with secretions. Disease, infectious mononucleosis. Clinical findings, pharyngitis, asthenia, fever. Laboratory findings, atypical lymphocytosis, oncogenic virus. And this is the question, okay? So you have to answer the question. So in the question, you write answer and you give the answer, okay? So can you please give me the answer to this question? Can anyone answer this question? Sorry. No idea? Can you please give the answer to this question? No, it's very late. I want to say here. Epstein-Barr virus. The answer to this question is Epstein-Barr virus. Okay? So this is an example of the questions that you will have in the exam. Fill in the blanks. The same as this one, but with bacteria, not with viruses. Any question about the exam?
No.
No questions about the exam?
Excuse me.
Yes.
Do each question have time limit?
That's yes, that's a very good question. That depends on the Sakai platform. I don't know because I haven't checked. I think the limit is for the whole exam. The limit is for the whole exam 1 hour. So each question, to my knowledge, does not have time limit. Okay, but I have to check.
So in short, you do not control this, right?
Sorry.
So you do not control this this time limit, right?
I can only control the time for the whole exam, but I have to check, okay? Because I don't know the Sakai platform, and we have never do that before, so we don't know how to use this. So your exam will be the first one, so we don't, well, the second one, so we don't know exactly. But to my knowledge, the time is for the whole exam, not per question. But I have to check because I don't know.
Any requirement on the camera or the mic?
The requirement is that you are honest. That is the requirement. If you are honest, we know that you will answer the questions without any help, okay? The problem with the microphone and the problem with the camera is that when we do it, the internet connection becomes slower. That is the problem. So I don't like to do an exam online. I disagree with this, but I have to do it. So we hope that students of medicine are honest and they answer the questions without any help. So for now, we are not going to require the camera or the microphone. We are waiting for instructions, okay? So maybe the requirement changed on Monday. But for now, I prefer not to use microphone and I prefer not to use the camera because I know that students of medicine are honest, okay? Because if you are not honest, you cannot study medicine. Any question? Questions?
No.
Okay, so the exam will not start at 9, okay? Because at 9, we will explain you the exam again with more detail. So maybe the exam will start 10 or 20 minutes later, okay? So don't worry, because at 9, we will explain everything again. So please, take care with your internet connection, okay? Find a place where you can use an internet connection safe. This is very important. This is the first time that we do this. So we don't know the problems that we can appear next Monday, okay? So please find a good internet connection.
Trên tinh thần là thứ hai chúng ta sẽ kiểm tra các bạn nghe. Rồi cố gắng tìm cái nguồn mạng cho nó ổn định một chút để chúng ta làm bài. Bởi vì cái ngày thứ hai đó chúng ta sẽ làm bài kiểm tra cho nên là chúng ta sẽ không có thời gian để học. Và chúng ta sẽ học một buổi khác là vào sáng thứ tư. Sáng thứ tư các bạn có lịch không? Có lịch hả em?
Không ạ. Sáng tư như không có lịch sao?
Vậy thì sáng thứ tư. Vậy thì sáng thứ tư chúng ta sẽ học tiếp hả? Được không bạn?
Dạ được.
Được ạ.
Okay, so on Wednesday morning at 7 we have class. Okay. More questions?
I think no.
Anything else? No? Okay, so we stop. Goodbye, good luck, and we will meet on Monday at 9. So we finish the meeting.